and welcome to Building Cross-Sector Collaborations to Promote Effective Antibiotic Use in Inpatient, Outpatient, and Long-Term Care Settings. My name is Julie Sharp, and I am a Performance Improvement Specialist for the Public Health Foundation. We are excited to have you all here with us today as two states share their stories of cross-sector collaborations in antibiotic stewardship. Since 2015, PHF has worked with the Centers for Disease Control and Prevention on a project to interview health departments about their work in antibiotic stewardship. A total of 19 interviews were conducted and over 300 resources were cataloged. One interesting area from this project was the collaboration between public health and healthcare in developing antibiotic stewardship programs, promoting effective antibiotic use, and reducing healthcare-associated infections. Today's presentations from two of our interview sites will describe how they have been successful in establishing and maintaining these cross-sector collaborations and how these collaborations have led to practice improvements. Next slide. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Today's broadcast is being recorded and will be posted on the PHF website within a couple of weeks. We've taken a screenshot of the attendee interface. You should see something that looks like this on your own computer desktop in the upper right corner. You're listening in using your computer speaker system by default. If you would prefer to join over the phone, just select telephone in the audio pane and the dial-in information will be displayed. You can access the slide deck by clicking on the Handout tab and downloading the file. You will have the opportunity to submit text questions to today's presenters by typing your questions into the questions pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of the presentation. If you experience any technological challenges during today's webinar, type that into the chat box as well and we'll try to help you troubleshoot. Next slide, please. We would like to thank the Centers for Disease Control and Prevention for their support, which has allowed this webinar to be brought to you today. We want to reiterate that the presenter's information is their own and is not necessarily representative of the views of the CDC. Next slide, please. PHF is a national nonprofit organization based in Washington, D.C., focusing on improving the public health by strengthening the quality and performance of public health practice. Our work is focused in three primary areas: quality improvement, performance management, and workforce development. You can learn more about our work at our website, phf.org. Next slide, please. We have a set of 4 learning objectives for today's webinar. We expect that by the end of the webinar, you will be able to describe how cross-sector collaboration can improve antibiotic stewardship programs, list at least 3 outcomes or impacts that have resulted from cross-sector collaboration in antibiotic stewardship, identify best practices to developing cross-sector collaboration in antibiotic stewardship, and identify and avoid potential pitfalls to developing cross-sector collaboration. Next slide, please. We are honored to have 4 presenters sharing their collaboration stories with us today. First, we will hear from Dr. Marisa DeAngeli and Aimee Ford from the state of Washington. Marisa is a medical epidemiologist from the Washington State Department of Health, and Aimee is a quality improvement consultant for nursing homes at Qualis Health, the quality improvement organization for the state of Washington. Washington State Department of Health is funded under the CLC-ELC K2 grant to combat antibiotic-resistant bacteria, including by promoting antimicrobial stewardship. Next, Suzanne Williams and Scott Bergman will share the story from Illinois. Suzanne is an antimicrobial stewardship project associate in the Division of Patient Safety and Quality at the Illinois Department of Health. Scott is the antimicrobial stewardship coordinator for Nebraska Medicine, the health system of the University of Nebraska Medical Center, and holds a faculty appointment at the UNMC College of Pharmacy. At the time of the project, he was an associate professor at Southern Illinois University Edwardsville School of Pharmacy and SIU School of Medicine. Thank you very much to the 4 of you for being here with us today. With that, we'll get started. Marisa and Aimee, I'll hand it over to you.
Okay, good morning, everyone. This is Marisa DeAngeli, and Aimee Ford and I will be discussing a partnership to promote stewardship in nursing homes. Next slide, please. Sorry, I'm having problems. Here we go. So in order to describe the current program, I need to explain an earlier program called Equip for Critical Access Hospitals. Equip stands for Education, Quality, and Infection Prevention. And the original program was developed by Qualis Health using funding from Centers for Medicare and Medicaid Services and was implemented in 2015 in partnership with the Washington State Department of Health and other organizations listed here, including our state chapters of the Association for Professionals in Infection Control and the Washington State Hospital Association. So the group of partners recognize that infection preventionists in critical access hospitals have many demands placed on them, yet have very few resources. IPs in critical access hospitals wear many hats, overseeing infection control, employee health, staff training, and quality improvement, among others. And sometimes they have minimal specific training for their role. They may be the only IP expert in their community. They lack organizational support for accessing education in infection control and may feel isolated, resulting in high job turnover. So the goal of Equip for Critical Access Hospitals was to increase confidence and proficiency of infection preventionists in critical access hospitals by providing education in the core competencies of infection prevention as recognized by APIC and also the Certification Board of Infection Control. Next slide, please. So the Equip model has 4 components, including education with monthly webinars and an annual in-person meeting, mentorship with mentors available to field questions and direct the questioner to resources, collaborative learning, and promotion of tracking and sharing of pertinent data with quality improvement embedded in the program. So in 2016, the annual Equip for Critical Access Conference focused on antimicrobial stewardship in critical access hospitals and introduced a Jumpstart Stewardship workbook that provided a step-by-step project management style approach for establishing a right-sized, sustainable antimicrobial stewardship program in a critical access hospital. Next slide, please.
Hi, this is Aimee Ford, and you heard Dr. D'Angeli talk about what gave the foundation for our current work with skilled nursing facilities. But I think in talking about what makes a cross-sector partnership successful, we're using this graphic that we typically use in learning sessions with nursing homes to illustrate that we don't just function as a group of people who work together. We're really functioning together as a team. What makes our partnership successful is that we're united by the same goal to advance infection prevention and antimicrobial stewardship in long-term care settings to improve the lives of residents. And this goal aligns with each of our members' work. And we also understand and respect each of the roles that we have, that we bring to the table in achieving this their aim. So for example, the Department of Health brings the expertise in infection prevention and antimicrobial stewardship. Qualis Health has relationships with the nursing homes and in the broader long-term care community. So because a lot of the QIN, QAO work is focused on convening stakeholders and disseminating best practices, we're expert collaborators. Other team members who we are working with include nursing home providers, the state survey agency, infection preventionists, and experts who are both medical doctors as well as nurses, epidemiologists, a long-term care medical director, the national nursing directors, representatives, long-term care trade associations, and a family member, so that we not only have additional expertise in infection prevention and a deeper understanding of the dynamics of the nursing homes, but we also have the input of the end users who are going to be directly impacted by this system. And next slide. So another example of how we partnered effectively was the education that we provided to the nursing homes through our antimicrobial stewardship summit. So as probably most of you know, in July 2015, CMS released the proposed rules for sweeping changes to nursing homes, which included proposed regulations to strengthen infection prevention programs in nursing homes, and it compelled them to develop antimicrobial stewardship programs as well. Antimicrobial stewardship was really new to nursing homes at that time, and it still is pretty new to them right now. But about a year ago, the committee members made a commitment to develop curriculum for a stewardship summit, and 3 months later in April, in partnership with a trade association with local health departments, we began conducting stewardship summits for the nursing homes and some assisted livings in 3 locations across Washington, and we gave some presentations in 2 other locations in the state. And while we may not have had the same presenters or disciplines for all sessions, we did adhere to core content. Now, in addition to sharing information about the antimicrobial stewardship practices with nursing homes and learning more about what they needed to be successful, the other benefit was that we got to strengthen our partnerships with the local health departments and stakeholders, and by working together help to minimize duplication of services. One last thing I want to mention on this slide is that while we have a pretty cohesive team, I don't think our summit would have been quite as successful without our family representative involved. She not only provided some input into the curriculum, but at our kickoff session, she participated on a panel discussion about implementing a stewardship program in long-term care, which was very well received by the attendees. And we found that she provides some insightful comments and a unique perspective, and her involvement with the committee has helped to reinforce to providers and to committee members that we really can't push for any improvement without the voice of residents and families who are to be involved with that. So in this next slide, we provided a snapshot of some of the feedback that we received in our first summit of what providers will do differently based on what they learned that day. So, for example, tracking antibiotics, provide some training for the nurse practitioners, working with pharmacy to improve antibiotic use, and so forth. We were very pleased to see that for the most part, providers are very interested in stewardship and they're hungry for more information. Not surprisingly, some of the barriers to being able to move forward with implementing stewardship include leadership turnover, medical directors or prescribers not aware of the initiative, prescribers and other clinicians who are don't have buy-in to stewardship, and a lot of it is also family pressure for antibiotics. So the information we received from providers was helpful to build a foundation for EQUIP in long-term care. I'm going to turn it back to Marisa for a few minutes to discuss this. I'll change the slide.
Okay, great. So I think Aimee actually already covered some of this, but with funding from the U.S. Centers for Disease Control and Prevention in the epidemiology and lab capacity grant, we set out to apply the EQUIP model to the long-term care setting, specifically in nursing homes. And the main goal was to help skilled nursing facilities meet the new CMS requirements that Aimee described, to have an infection prevention and control officer with specific training in infection prevention, and to have an antimicrobial stewardship program. So to roll out EQUIP for long-term care, we brought together many of the same original EQUIP partners, including the Washington State Department of Health and Qualis Health, but and also APIC. But we also brought in the Idaho Department of Health, since Qualis is the QIO for Idaho as well. Our state survey agency, the Department of Health, Social and Health Services that regulates nursing homes, the trade associations, nursing home leaders and staff, and then the family representatives. Next slide, please.
So both the Department of Health and Qualis Health have gathered data from our SNF providers, both collectively and individually, to get a glimpse of what antimicrobial stewardship and infection prevention preparedness in the nursing home facilities in Idaho and Washington. So, for instance, Qualis has collected data from the annual facility survey of the NHSN cohort, which is our work group. And our work group gathered data from the gap analysis survey summary, and Department of Health itself obtained data from the infection control and assessment surveys. So this and the next slide are going to highlight some of the key findings and opportunities that we've identified to support nursing homes. For example, on this slide, we've got a graphic from data from the annual facility assessment of the NHSN cohort. And this only represents about 52% of the cohort. So it's not representative of all the nursing homes in Washington State, but it provides a useful glimpse of where nursing homes are with their development of their stewardship programs. So, for example, in the question of who is the antimicrobial stewardship leader in your facilities, we found that 13% have not had any designated lead. It seems that most are, that 40% are either led by the medical director or by the by other, which is typically the staff development coordinator, who usually is also the infection prevention point person in the building. 0% of those homes have a DNS as a leader, and about 7% have a pharmacist leader. So I'm going to turn this back to Marisa to talk about the data that DOH and the group has obtained and how this is going to be used to develop equip in long-term care.
So this graph shows a comparison between two different sources of information about how well nursing homes meet the CDC core elements of stewardship. And so I'll just describe where this information comes from. The light blue bars on the left represent results from the gap analysis survey that was distributed to 212 nursing homes in Washington and 77 nursing homes in Idaho. At the time that this was summarized, we had 94 responses for a response rate of 33%. That was a little bit before the time that the survey closed, so I'm hoping that we'll actually ultimately have a better response rate. And the dark blue bars on the right are results from the on-site assessments in 20 Washington nursing homes. These assessments are called ICAR assessments. It stands for Infection Control and Response. And these assessments follow a specific checklist provided by Centers for Disease Control in order to assess and improve infection prevention in these healthcare facilities. So just to clarify, the GAP survey was self-assessment, and the ICAR is on-site with a public health practitioner making the assessment. And so the height of the bar shows the proportion of respondents that met the core element. So I'm not going to go in detail through every single element, but you'll see that at the bottom it identifies what the core element is. And so, for example, about 20 to 50% of these facilities do not have a leadership commitment to stewardship. About 20 to 30% have no accountable individual identified as being responsible for ensuring the success of the stewardship program. About 30% have no access to expertise in stewardship. About half have no policies to promote stewardship. 30 to 50% have no practices in place to promote stewardship. 40% do not get pharmacy reports on antibiotic use. Sorry, let me go on down. As far as providing feedback to providers, about 50% do not provide feedback to providers about their antibiotic use. And then the questions were slightly different between the data sources. But according to the GAP survey, about 40% of nursing homes provide no education to staff on stewardship. And then according to the ICAR assessment, about 70% do not provide stewardship education to nurses, and more than 80% don't provide stewardship education to providers. So as you can see, there is a lot of work to be done, many opportunities for improvement. Next slide. So that's not you though, right? So this table shows the table of contents of the Jumpstart Stewardship Workbook that has been revised for nursing homes. And the material draws on resources from Centers for Disease Control, the Agency for Healthcare Research and Quality, the Greater New York Hospital Association, among others, and it was edited by our EQUIP Steering Committee. And the workbook covers the following steps: how to perform a current state assessment, how to identify key stakeholders for stewardship. It explains how to build a stewardship team, how to select stewardship interventions and targets for implementation, how to measure effectiveness, including identifying data sources and key metrics, identifying and mitigating barriers, planning the intervention and creating a timeline for implementation, and then writing a project charter and strategic plan to formalize the program. And so this next slide shows a driver diagram created by the Public Health Foundation that describes public health's role in promoting optimal antibiotic use and the primary and secondary drivers that support the goal. And the next slide then shows, the large arrows show some of the things that we're doing in Washington to promote stewardship in nursing homes. And these include promoting standardization of assessment, communication, testing, and treatment for common infectious syndromes in nursing homes like UTI, respiratory infections, and skin and soft tissue infections. Providing surveillance reports on multi-drug resistant organisms to raise awareness among local health and healthcare professionals. Encouraging best practices in facilities for infection surveillance, infection control, and promoting access to expertise in pharmacy, microbiology, and measurement of antibiotic use. Publicizing the excellent stewardship resources from Centers for Disease Control, AHRQ, and the Choosing Wisely campaign. And promoting stewardship education for all residents, families, and staff in nursing homes. And finally, encouraging facilities to have an intervention plan with targets and metrics. Next slide.
So we don't have enough data over time to demonstrate results that have showed the success of our cross-sector collaboration in antimicrobial stewardship, but we do know through the GAP survey, the ICAR assessments, and our presentations that more providers are understanding the basics of an EMS program, though we also recognize that to some degree nursing homes are incentivized by the final rule. Which again is mandated that nursing homes have to have an EMS program, which goes into effect November 28, 2017. So in coming together, we're amplifying the message of the importance of antimicrobial stewardship and the message that nursing homes have a strong resource base to support the stewardship development. They don't have to reinvent the wheel, so to speak. So while our collaboration has been smooth for the most part, we are mindful that we have some competing deliverables. So for example, Qualis has to recruit about 60 more nursing homes to work in developing the antimicrobial stewardship programs and other items that we're working with nursing homes for improvement. The Department of Health has a grant to work with nursing homes to develop antimicrobial stewardship. However, it's worked out to be a positive because we found that the Qualis Health can provide the basics with the input and expertise of the Department of Health. And Department of Health has the resources and the expertise to advance antimicrobial stewardship further, and we can work with the Department of Health to identify those homes that are well positioned for that. But we know that that may not always happen in cross-sector collaboration. Another potential pitfall is that with competing priorities, committee members are not always able to attend all meetings, and that can diminish the richness of input. And finally, anytime you get a group of people together from diverse backgrounds, there's always going to be a risk of personality conflicts and conflict in working styles. And I think we've been lucky that the members of the group are really strongly vested in achieving the same goal. And it's also helpful that Marisa, who leads the group, is a skillful facilitator. Let me move on to the next slide here. Okay, so to conclude our presentation, a fruitful collaboration begins with setting some clear goals for the project, goals that support the existing work of collaborative members and includes people who are at the receiving end of the stewardship program. So in our case, staff members and also a family member. Success isn't just dependent on members having the appropriate background or expertise, although that of course is necessary. But to collaborate effectively, the members also need to be vested in achieving these goals and able to put the success of the project ahead of personal gain. Current research on effective teamwork and communication supports that hierarchies be flattened to help members feel safe to speak up and participate, and we've achieved that very well in this group. And it's also been helpful to have a few people who are on the team who work together successfully, because that helps to further foster an atmosphere of trust between members. And I think that concludes our presentation. Thank you very much.
Thank you so much, Marisa and Aimee. Next, we're going to hear from Suzanne Williams from the Illinois Department of Public Health. Suzanne?
Yes, thank you. Let me see. I should have the option to advance slides, is that correct? Let me see.
Yes, you do.
There we go. Okay, so today I'm going to discuss how we collaborated with a multi-stakeholder work group to develop the Precious Drugs and Scary Bugs campaign, which is a statewide initiative that aims to promote the appropriate use of antibiotics in the outpatient setting. Antibiotic overuse is well recognized as an issue. In 2013 to 2014, there were 853 antibiotic prescriptions per 1,000 people in Illinois based on the Exponent database from Quintiles IMS. On the map created by CDC, community antibiotic prescribing rates are shown by state, with the lowest rates in yellow and the highest rates in the darker red. As you can see, Illinois is right in the middle, so there's a lot of work that can be done to lower inappropriate prescribing. Superbugs, such as C. diff, is an example of an urgent public health threat directly related to inappropriate antibiotic use. C. diff, which causes life-threatening bacteria, is occurring more in community settings, and in Illinois, over half of the 15,000 cases of C. diff infections in hospitals reported to NHSN in 2015 were community onset. The trial described on this slide is what inspired the core intervention of the Precious Drugs and Scary Bugs campaign, which is the use of a customized public commitment letter. The study tested the letter in 5 outpatient primary care clinics. The poster in the study featured provider photos, signatures, and had a letter that stated provider commitment to avoid inappropriate antibiotic prescribing for acute respiratory infections. The study had very impressive results, with approximately a 20% reduction in inappropriate prescribing in only 12 weeks. So the goals of the campaign are to increase provider and patient knowledge, provide resources, and improve coordination and exchange of best practices between stakeholders. Participation in the campaign involved 4 different activities that can take place over a year. Campaign sign-up is a 2-step process to engage both facility leadership and individual providers. Once we received facility commitment, we would send each provider their own commitment form to complete so that they could make their own personal commitment to prescribe antibiotics judiciously. After sign-up, IDPH would customize the commitment poster with provider names and pictures and would instruct facilities to hang the posters in each of their exam rooms. We also hosted various educational webinars and distributed brochures and symptomatic relief prescription pads. And then finally, we evaluated the campaign using pre- and post surveys, provider interviews, and by analyzing antibiotic prescribing data from a subset of participating facilities. So this is the commitment poster that we used in the Precious Drugs and Scary Bugs campaign. The poster highlights specific messages such as antibiotics only fight bacterial infections and antibiotics may not work when they are needed if used inappropriately. The letter states a commitment from the provider to avoid prescribing antibiotics when they will do more harm than good. We have received very positive feedback on the commitment poster from participating providers. Over 55% of post-survey respondents agreed that the poster has encouraged judicious antibiotic prescribing for acute respiratory infections, and over 65% stated that the poster increased or facilitated conversations with patients about appropriate antibiotic usage. So one provider stated, "The value that I see to it is that patients see it and read it, and it paves the way for you, but it's more than a constant reminder to do the right thing and not give in. It makes you take the time commitment to talk to the patient." So this is a list of organizations that were part of our work group, and we held monthly calls to develop and implement the campaign. One of our work group members were the researchers from the Behavioral Nudge Study out of the University of Southern California. We also recruited other work group members using our statewide Healthcare Associated Infection Advisory Council and by hosting a stakeholder informational call where we invited additional groups to join. So the campaign work group helped us in 2 crucial ways: facility engagement and campaign tool development. In order to recruit outpatient facilities for campaign participation, Workgroup members invited us to present at meetings for their medical directors and allowed us to use their communication outlets such as newsletters and email lists to reach out to outpatient facilities. The Workgroup provided input on the development of various campaign tools. For instance, they provided feedback on an implementation guide for participating facilities which incorporates best practices and lessons learned for introducing and using the commitment poster. The Workgroup helped in commitment poster design, creating an evaluation plan, reviewing the pre- and post-campaign surveys, developing scripts for provider interviews on commitment poster utility, and by providing feedback on our data collection methods. So my co-presenter, Scott, will discuss his experience participating in the Workgroup and implementing the campaign in his facility. His former group, Southern Illinois University School of Medicine, were antibiotic stewardship champions and helped with developing content and presenting on webinars and by providing technical assistance to facilities that were working on pulling antibiotic prescribing data. So now we'll turn it over to Scott to share his experience.
Thank you, Suzanne. As was mentioned in my introduction, I have since moved from Illinois to Nebraska, but I've still kept up with this project and tried to help as much as possible. At the time the project started, I was working for Southern Illinois University and representing the Illinois Pharmacists Association as the anti-infective expert in the organization with the IDPH Advisory Council. And much of that passion and interest continues in my job today, spreading the good word of antibiotic stewardship to Nebraska. Let's see if I can get to the next slide. When I was working in Illinois, my office was in Springfield, near the state capitol, on the medical school campus, and there were 4 different family practice clinics that the SIU Department of Family and Community Medicine ran. And one of my collaborators was a physician's assistant in that Decatur clinic who signed up for this program, and he was also on the advisory council and interested in antimicrobial resistance. And the other site that we signed up was in Quincy, and you can see from the map these downstate clinics. Springfield is right in the middle of the state and in the middle of these clinic areas. So I was like the hub of the wheel with the spokes turning, trying to communicate with the different clinics, and that's pretty similar to my job in academics at the School of Pharmacy, because the school was in St. Louis area's metropolitan district in Edwardsville, so I was about 80 miles away from the College of Pharmacy, working with the physicians at the School of Medicine. And being a large state and pretty rural downstate, that's something that we can relate with for other states, trying to implement these systems. One of the nice things that I walked into was that this PA had already started a collaboration with different hospitals in the area looking at antimicrobial resistance. And one of his first projects was to assess different susceptibility rates for commonly encountered pathogens for community practice physicians to be able to share what our local susceptibilities were. He developed this website and this group within the School of Medicine and its clinical partners called the Downstate Illinois Partnership Against Antimicrobial Resistance, or DIPAR for short. And you can see that the screenshot even had the Precious Drugs, Scary Bugs campaign at the bottom, trying to get the word out about this collaboration. So even among these 4 different clinics that the family practice department operated, there was still a need to enroll sites and get them committed to change. And one of the jobs that we had was to explain the program, get them excited about it so that it just wasn't another initiative, because if any of you have worked in healthcare and the clinics, they get kind of sick of new initiatives every few months and trying to keep up doing more with less resources. So I think that one of the selling points of this program was that it was fairly a low-key intervention. It didn't have a lot of steps in it or paperwork, documentation. It was simply, here's a poster to bring it to your attention, to bring it to your patient's attention that this is an issue. And I think we've seen these posters before, many of us, and I like to describe it as similar to the public health initiatives about washing your hands when leaving the restroom. But it's much more specific when it has the provider's name and picture on it and engages them. And it has a lot to do with the behavioral change model and getting providers to change, but also getting the patients to understand that this is an issue you care about. And like Suzanne said, it really opened up the dialogue. But that being said, it didn't mean everybody wanted to participate. I think everybody agreed that it was a good idea. 2 of our sites declined. One of them in Carbondale is at the very southern tip of the state and just geographically was a little farther away. It's about 3 hours from Springfield to drive, and they weren't immediately on board, so we thought it's better to let them do their own thing, pilot it in these 2 clinics that have the champions at it. Springfield was actually a site that didn't participate because they were undergoing remodeling and expanding their clinic, and they didn't want that to have another distraction, and the posters would probably be moving and providers wouldn't be using the same rooms. So some of those logistic challenges come into like real life settings. But I think it is key that you have at least one local champion, and in this case I mentioned it can be a physician assistant or other mid-level practitioner that's really engaged to get the ball rolling. And then we did receive buy-in from the medical director and facility leadership, the School of Medicine CEO of the clinical innovation anyway was a family practice physician, so he was very supportive of this. Our quality department is very well integrated. It doesn't always mean things run entirely smoothly, as you'll see, but at least the commitment from the organization was strong. And then getting the message out to the different providers. There were about a dozen faculty at each of these clinics that were participating, and it was a mix of mostly physicians, but also several mid-levels at each location. And then because they're teaching sites, there were also 15 different residents in the programs rotating through, most of them having at least some clinic experience every month. So they're generally a captive audience that you can educate and encourage to change practice. And as part of our downstate partnership philosophy, education was a big piece, and getting these providers to understand the issue early on in their career is, I think, important for all of us. So as far as our efforts go, we put up the commitment posters, and we were specifically focusing on acute bronchitis and acute respiratory infections in our educational process. So we also had an educational webinar with the statewide group, anybody that wanted to participate, to share some of these same experiences early on, and then encourage participation as IDPH was signing up more sites. We were a pilot group to see what would be the most efficient use of everybody's time once we got more signed up. So the PA and I had both contributed different educational material during different sessions, and there was also another champion at one of the sites that participated in another event. And finally, the evaluation piece. I mentioned piloting this program, getting it off the ground. We had several steps in that evaluation process and getting data out. And as many of you know, in any project or research, getting those first patient cases really reveals a lot about what you've thought of and done right, and sometimes what you haven't thought of. And then afterward, evaluating and interviewing providers. That was part of the process that Suzanne mentioned, getting some feedback on the process. So I said 2 clinics were enrolled, and then 2 have not, which can make a good control group as well. One of them has reported data so far, and we're still working on pulling the data from the other one. We are having a little bit of difficulty and different EHRs across different sites and different people in the IT departments too. One of the things we learned right away was it was helpful to cross-check some of the data from the IT department to make sure that the data they were sending us was really what we wanted. Not that we didn't trust them, but just that sometimes the computer doesn't speak the same language that we're thinking of. And we were able to get some valuable feedback by having a resident work on this as part of a quality improvement project. It was also valuable in terms of an educational task. And now Suzanne can tell you more about signing up clinics, but we're getting larger health systems and not necessarily just academic centers interested in this process to try to recruit more as part of the campaign. So here's our results from that first clinic reporting data. You can see starting on the left is the acute bronchitis visits, and high bars here mean that it was an appropriate prescribing rate. So antibiotics were withheld for these indications that are not reasons to be giving antibiotics. Short courses of acute bronchitis are generally not considered to need antibiotics. So we did see a statistically significant improvement in our prescribing rate from 59% up to 71%. So that was very good. And with acute respiratory infection, one of the things we noticed was that our clinics do a very, very good job of not prescribing antibiotics on that initial visit where this is simply the common cold symptoms and there's really no reason to give antibiotics except for simply patient satisfaction or that reassurance that this could be a bacteria, but it's very, very unlikely. That poster really helped encourage dialogue, we thought, but what we didn't know is that we were already doing a good job at discouraging antibiotic use. So ironically, our prescribing rate actually went down or worsened a little bit, statistically even, in that second phase. One of the things you may also notice is that our visits went down, and this we think is an artifact due to our electronic health record changing. If you remember this, pretty recently we moved from ICD-9 to ICD-10, and our original electronic health record is not going to support ICD-10, so we had a massive change across the health system to change our clinic electronic health record to a product that would support ICD-10. The way things are coded are a little bit different in ICD-10, so we may be missing some people in that second group that we were counting in the first half. And one of the lessons learned from that pilot and the resident quality assurance process was that looking for primary versus secondary diagnoses, and also the exclusion criteria is important, because in our first batch of patients in the acute respiratory infection group, we were seeing a lot of pediatric patients flagged and they had received antibiotics, but when you looked in the diagnosis codes, acute otitis media was actually a secondary diagnosis. They had charted as a primary the acute respiratory infection. So our understanding of that is acute respiratory infections are viral, but acute otitis media may have some indication for antibiotic. You can argue about trying to discourage that as well, but in our initial study we weren't trying to capture those patients, so we ended up excluding them if it was in any diagnosis. We had assumed that that would probably be the primary diagnosis when we started, but sometimes physicians think differently or just check the boxes differently than we expect. COPD was another one that we got asked about as the new health systems are joining, and how do we approach these patients and the pilot data. And to us, that's a chronic disease that was listed as an exclusion criteria. We weren't specifically targeting that with this intervention. If somebody had a COPD exacerbation, that was going to be treated and evaluated differently than acute respiratory infections and acute bronchitis. So it was not always coded for in the visit though, so we had to make sure to include that. If the patient had ever been diagnosed with COPD, we are under the assumption that they still have COPD. The provider just didn't assess the severity of that pulmonary disease at the visit, so they weren't coding for it. So making sure we're able to pull those chronic diagnosis codes in and exclude those patients was a lesson that we learned. And then finally, we did see some patients showing up on our antibiotic list that were getting eardrops, for example, and probably along the lines of the otitis that we weren't expecting, and it was because I had included trimethoprim sulfamethoxazole, and trimethoprim was triggering these eardrops and the trimethoprim polymyxin combination or polytrim drops. So those were being charted as patients that received antibiotics, and we were not looking for those in our initial counts, and we were able to filter those out after having gone through this pilot process. So I hope that gives you some understanding of what we went through, and if you have further questions, I'd be happy to answer them, as well as Suzanne and the other members of our panel as we finish up here today.
Great. Thank you so much, Scott. Thank you to all of our presenters for their great information today. Thank you for those of you who've sent comments or questions along the way. Please continue to use the chat box to send additional questions or comments. We'll take some time now to answer as many of the questions as we can. If time does not allow us to get to all of the questions today, we will follow up with some documents and some links to all of you. Janelle or Vanessa, could you share our first question?
Yes, thank you, Julie. So for our first question, we had someone ask for a link to the Jumpstart Stewardship Kit, and Julie Sharp has put that link into the chat box. So if you go check the chat box, you should see the link to PHF's Public Health Antibiotic Stewardship driver diagram, as well as the link to Washington's Jumpstart Stewardship Kit. And we'll send those out with the archive. We'll post them on the page. And then we had another question for Washington. Where are you getting the data for the nursing home surveillance report that you mentioned?
Oh, go ahead. This is Aimee Ford. First of all, just a note that the Jumpstart Stewardship workbook that is available right now is the one for critical access. The long-term care workbook will not be available for about another 10 to 14 days. So just it'll be on the same website, but just be aware that the long-term care one is not ready. Now, the second question of where are we getting data for surveillance? The data that we presented came from three parts. One was the annual facility survey that comes from the National Healthcare and Safety Network cohort, which is a group of nursing homes that were recruited to start entering data on Clostridium difficile infections into NHSN. Secondly, the Antimicrobial Stewardship Workgroup developed and sent out a gap analysis survey to assess antimicrobial stewardship practices. And that was sent out to all the nursing homes in Washington and Idaho. So that was the second source of data. Then the third source of data that the Department of Health put out was?
Those were the ICAR assessments, the infection control and response assessments. However, I understood that question differently.
Sorry.
So because I think the question was about surveillance reports. I'm just wondering, could you read the question one more time?
Definitely, yeah. So it's where were you getting the data for the nursing home surveillance reports that you mentioned in the presentation?
Okay. Yeah, so I don't know, maybe that person can write in. If you're talking about the surveillance reports of multi-drug resistant organisms, the Department of Health Communicable Disease Epidemiology just produced quarterly reports on MDROs. And right now our surveillance covers carbapenem-resistant Enterobacteriaceae, and so it's not only nursing homes, but it is statewide surveillance, so nursing homes are included in that reporting. And this year we're expanding to include carbapenem-resistant Acinetobacter and Pseudomonas. we're actually going to be expanding our surveillance reports as well using other existing data sources. But for right now, it's actual submission of isolates with carbapenemase testing performed at the public health lab. So anyway, hopefully we covered that question one way or another.
Yeah, I think you did. They just wrote in again the MDRO surveillance report, so it sounds like it was what you were thinking. Great. All right, so our next question is for Illinois. Someone was wondering what the dimensions of the poster that you used in the Illinois intervention was. Do you have more information, details on that?
Yes, this is Suzanne speaking. So we gave the facilities two options. The first was an 18 by 24, and we initially got the feedback that that's a lot of space to take up in a smaller exam room. So we started offering a 16 by 20 inch poster option as well. So we didn't want to go any smaller than that, just because the print can get hard to read. But yeah, that's the size.
And I think, Suzanne, fitting all the provider pictures on it was one of the reasons for the size, if I remember right. And in the case of academic clinics, it was just the attending faculty, physicians, or mid-level practitioners that had agreed to be on the poster that we used, not every single resident.
Yes, exactly. So in the study that tested the poster, they had like one provider and their one name, and they were always practicing in that one exam room. And we found when adapting that to real life, it's not really realistic that one provider is using that same exam room all the time. So that's why we came up with the method of putting all pictures and all names for everybody that's practicing or could be practicing in it. So yes, that's part of the reason why we went to that size, just so we could squeeze as many providers and names in there as possible.
Great, and sort of building on that, we had a follow-up question about the posters. Did most of the facilities frame the posters, or did you laminate them at all?
Yeah, so no, most of them, so we're able to do some site visits with some of the participating facilities, and we did have them laminated just so the posters can be sprayed and wiped down. And so since we sent them laminated, the facilities chose to just stick it up on the wall with tape. I don't think I noticed anybody frame the poster.
Yeah, I would agree with that. One of the other lessons we learned from Southern California was that they started with the signature of that one provider as more of a letter poster, and they found that patients were trying to take pictures of the signature and make prescriptions out of it. So we were told not to put signatures on our poster, and I think we just had names because of that, and it served the same purpose.
Great, thank you. So we have another question that I think is for all the presenters. Evidence of effective interventions is key to rolling out stewardship interventions more broadly. This continues to be a challenge, and how are your programs building this evidence?
Could you repeat the question? My AC heater kicked on and I couldn't hear all the details at the beginning.
No problem. So Jacqueline said that evidence of effective interventions is key to rolling out stewardship interventions broadly. This continues to be a challenge, and how are your programs building this evidence?
Well, that's certainly from an academic standpoint one of the challenges with antimicrobial stewardship, but one of our goals as programs is try to share our information and publish and present. So we appreciated the Southern California group initially publishing their pilot study, and they've had cluster randomized trials to follow up trying to show that this can be replicated. So they're very interested in our results, and we hope to disseminate them more. But it does help with providers and physicians to show them some of the early results and encourage them that this is worthwhile. And I would agree with the statement, and I mentioned they get bombarded with a lot of different tasks and things that they should change, and if you can show them that this has been done before and is successful, that really helps with the success of the implementation.
And this is Marisa D'Angeli with the Washington State Department of Health. And that is one of the questions that we're actually grappling with. So one of the things that we would like to do in Equip for long-term care is have the opportunity for smaller groups of nursing homes to come together to work on intervention projects in a collaborative, and they would be expected then to share data amongst themselves. And so they would actually be tracking internally and keeping track of that data. One of the issues that we run into in Washington is that our public disclosure laws are very broad, and so we are very cautious about acquiring any data that could be released publicly. And so another thing we're looking into is IRB approval for any type of project that we're involved with. So those are the two of the issues. So for the current time, we're just suggesting that facilities monitor it internally.
Thank you all. And our final question actually came in before the webinar. The American Academy of Allergy, Asthma, and Immunology sent a question. They were curious if any of you were doing work around penicillin allergies. It sounds like some research has come out talking about how penicillin, a lot of folks think they have an allergy to penicillin. If you do testing, they don't, and it's a great alternative to some of these more resistant drugs. And if there's just a way you could comment on that at all, if any of you are doing work in that area.
I can comment on that from antimicrobial stewardship coordinator standpoint. And in Nebraska, we're working with our allergists to roll out those types of initiatives. And I can, I guess, share feedback from a acute care inpatient hospital side is always getting the allergists into the hospital is a challenge because of their busy clinic schedules. So we're referring patients that are having elective hip and knee surgeries that report a penicillin allergy to the clinic so that it can fit in with the allergist schedule. And they're very willing to accommodate them within that parameter, and trying to get those penicillin allergy off the lists of allergies if they're really not true. That's just a drop in the bucket for all the patients in our hospital reporting it, but at least those that are relatively healthy and going in for these procedures electively, that was a way we could manage the workflow. But yeah, we would love to have more availability and access to the testing and the expertise that allergists bring to antimicrobial stewardship, and I'm guessing the other groups can say the same. And
so this is Marisa D'Angeli. I just wanted to bring people's attention to the recent materials added to the CDC Get Smart website during Get Smart Week in November of 2016 does include a 2-page infographic about allergies, and we're actually recommending an exploration of a claim of penicillin allergy as a potential antimicrobial stewardship intervention that facilities can implement. So it can be just as simple as asking a few more questions to explore the symptoms that were reported associated with a supposed allergy, and if it's stomach upset or something like that, they can pretty much eliminate the allergy right there before even needing to get to an allergist evaluation.
I think that's a good point, and one of the areas we work on, and the pharmacists at the hospital help a lot with this, is putting in the comment box that they've tolerated this class of antibiotic, and often it's cephalosporins are safe in penicillin allergies. So at least having that information available in the comment section of our electronic health record helps a lot. And when they clarify that they're putting in that they've clarified they actually only had an intolerance, like you mentioned, and that they have taken penicillins or amoxicillin at home, so that it doesn't get relabeled as a penicillin allergy each time, because I've certainly seen that in the past where you could go to the effort of asking the questions and removing it, but if it could be a medical assistant intaking that patient sees or hears the penicillin allergy and gets rechecked that they have it, it can be very difficult to get off their chart again and keep it off.
Thank you so much both for addressing that and talking about how you're providing interventions in that area. So we do have one hand raised. Kelly, I'm going to try to unmute you so that you can ask your question. Kelly, are you there?
Hello.
Hi, Kelly.
Hi, everybody. Thank you for unmuting me. I just wanted to help everybody be aware. I'm actually a penicillin skin testing implementation specialist, and so my whole job is to help hospitals implement their penicillin allergy testing protocols. And I know one of the biggest issues that hospitals have is that allergy availability. And so just to remind everybody that it doesn't necessarily have to be the allergist. It could be pharmacy in some states. Pharmacists are allowed to administer, as well as nurses, infectious disease physicians, fellows, and residents. So if that is something that is part of your antimicrobial stewardship efforts, just to keep that in mind, that can also be a solution.
Thank you, Kelly.
All right. Well, we are past the top of the hour, so I'm going to just kind of walk us through a last couple of slides here. Wanted to make you all aware that there are some resources available from the Public Health Foundation and the CDC to support your work in antibiotic stewardship. The first of these is a recently released implementation framework for health departments. It contains links to vignettes from Illinois and Washington, as well as several other states. You can also see some of the resources that were developed by the states. Next slide, please. The Public Health Foundation provides resources, training, and technical assistance to support your work in quality improvement, performance management, and workforce development. Many of these also link with accreditation preparation efforts for public health departments. You can visit phf.org to view tools, resources, and information in these programmatic areas. Next slide, please. Finally, we would like to thank you all for your participation in today's webinar, and again to our presenters for sharing their stories with us. As the webinar closes, you should be directed to an evaluation. If you could please take a few minutes to provide us feedback on what you heard today, that will help us in the future. This concludes today's webinar. Thank you all very much and have a great day.